Welcome. My name is Janelle Gunn, and I would like to welcome you to the CDC Partner and Private Sector Call, an update on the COVID-19 response. We would like to thank you for doing all that you are to help protect your employees and communities during this unprecedented time. This call will be recorded and later posted on the CDC COVID website, and this call is not intended for media. Media can direct their questions to media@cdc.gov. Before we begin, I would like to remind call participants that the CDC COVID website has the latest information, guidance, and communication resources. Just since this call last week, new documents include childcare that remains open, resources for parks and recreation, and critical infrastructure workers who may have been exposed. Today's call is part of a series of calls to help keep you informed about the COVID-19 response and to hear and respond to your questions. Thank you to those who sent questions in advance. We batched these questions and looked for themes and common questions. Our plan today is to hear a situational update from a leader in our response, Dr. J Butler. Then he will do some Q&A based on the questions we received. I'm so pleased to be joined today by Dr. J Butler. He is the Deputy Director for Infectious Diseases. In this capacity, he provides leadership to the efforts of CDC's 3 infectious disease national centers and helps to advance the agency's cross-cutting infectious disease priorities. Dr. Butler has 30 years of experience in increasingly complex public health leadership and management positions. He is board certified in medicine, pediatrics, and infectious diseases, and has served in public health positions at the federal, state, and tribal government. I'll now turn it over to Dr. Butler for a situational update.
All right. Well, thank you, Janelle, and good afternoon, everyone. If anybody's out in Hawaii or further east than that, good morning to you. So as of today, there have been over 555,000 cases of COVID-19 in the United States. Unfortunately, there have now been over 26,000 deaths, and I just want to start by extending condolences to those of us who have been directly touched by that through loss of family or other loved ones. As we look at these numbers, it's amazing to think we're talking about a disease and a virus that we didn't even know existed only 4 months ago, and the world has been changed in ways that it'll never be the same again. So it's humbling as we continue to learn, but as we learn new ways to be able to address this virus and to improve the health of everyone. So what are we learning? A couple of things that I wanted to start by highlighting, and then I look forward to taking your questions. First of all, it's becoming more and more clear that not everyone is impacted by the virus in the same way. While everyone is susceptible, at least here in the United States, we find that African American people are overrepresented among those who are hospitalized. Last Wednesday, we were able to get some data out in an MMWR. There's also ongoing work in a number of locales that are repeatedly confirming this finding. We don't have a full explanation for that at this time, although some early analysis suggests that it may be related to the longstanding health inequities that people of color the burden that people of color have to bear, particularly related to chronic diseases such as diabetes mellitus, which we know is associated with higher risk of severe outcomes with COVID-19. There is some data out of New York, for instance, that shows that hospitalization rates among African Americans are about twice what they are among white Americans in New York State. We also are learning more about how the epidemic is spreading across the United States. This past Friday, we were able to get some fairly detailed analyses on the geographic variability of COVID-19 across the United States. So far, nationally, the rates of infection have been 120 per 100,000 persons, but there's a number of places where the cumulative incidence is much higher than that national average, particularly in New York City, where the cumulative incidence is 915 per 100,000, or to put that another way, nearly 1% of the population have been confirmed with COVID-19. Other jurisdictions with rates above that national average are New York State, New Jersey, California, Massachusetts, not California, Louisiana, sorry about that, Massachusetts, Connecticut, Michigan, District of Columbia, and Rhode Island. It also shows some of the temporal trends in the rates of COVID-19, and we actually see a little bit of reason to be encouraged in that the doubling time, that is the amount of time it is required for the number of cases to go up twofold, is actually becoming longer, and the rate of increase day to day is also falling, which suggests that the community mitigation measures that have been instituted pretty much across the country are having an impact on the rates of new infection. I think if you called into this call before, you've heard us talk about flattening the curve. In fact, unless you've been living under a rock, you've heard everyone talk about flattening the curve. It's terminology that is very familiar to those of you who've been involved in pandemic planning for any number of years, but now it's become a household term, that when we take these steps to be able to slow transmission, we're distributing the impact of the pandemic over a longer period of time so that the pandemic does not crush the healthcare system or the critical infrastructure that keeps the water flowing and the lights on. The third area of learning is a deeper dig into community mitigation, and just today we were able to get some of that information out in the MMWR, and all of the MMWRs are available online if you go to cdc.gov/MMWR, or if you go to cdc.gov/COVID-19, you'll also find links to the recent publications in the MMWR. The one that came out today looked at community mitigation and the rates of disease in 4 locations that were hit pretty early in the pandemic: Seattle, San Francisco, New Orleans, and New York City. One of the things that I think is most interesting about this report is how we can take fairly traditional public health data and overlay it with other types of data. In this case, data from SafeGraph as a home measure. This is data that comes from the GPS on cell phones that indicates how often people go beyond about 150 meters of where the phone has spent the night before, as a measure of movement throughout the day. And it shows that the community mitigation efforts have reduced the amount of leaving the home significantly in all of these locations. In New York, it was nearly a twofold decrease in the amount of time spent away from home. This is really important as we look at how do we begin to peel back some of the community mitigation efforts. We know that it's always a fine line to walk between keeping people from becoming sick, but also getting the economy going again, recognizing that the longer that the economy continues to decline, that too will have a negative impact on people's health. We also recognize that there are a lot of things that are being delayed right now, particularly as it relates to chronic disease management and primary care in the healthcare sector. And that will eventually be causing health impacts that will be negative as well. So the overall goal is to be able to begin to lighten up some of the mitigation efforts sometime in the coming weeks and months, but doing it in a way that hits the right balance to be able to support getting life as much as possible back to normal, but without causing large second waves of COVID-19. We do have concerns as we've watched the experience in other countries that were ahead of the United States, particularly in Hong Kong and South Korea, where there have been some reports of resurgences as community mitigation was backed off. Also in Singapore and Japan, where there's been increases recently in the number of cases related to more open travel. Finally, I wanted to highlight something that if you follow influenza statistics and are familiar with CDC's flu view, you may find COVID view sort of a familiar environment. This is available on the CDC website, and it's weekly updates in the amount of COVID disease that is occurring around the country, and it includes COVID-like illness. If you're familiar with influenza-like illness, it's a measure similar to that, and it's one of the ways you can see that there actually has been some decline, at least in terms of healthcare seeking related to COVID-like illness over the past week. It also shows mortality figures, and just as an example, over the week ending April 4th, 7% of all deaths in the United States were caused by pneumonia, excluding influenza in COVID-19, but there was another 7% of all deaths that were related to COVID-19. The influenza number of deaths has actually declined over the past several weeks and is now less than 1%. So overall, we're seeing a combined pneumonia and influenza death rate, including those caused by COVID, that are approaching the levels that we saw about 2 or 3 years ago when we had a particularly severe influenza season. However, this is all being compacted into a period of just a few weeks, so a very serious situation. And finally, I want to talk a little bit about prevention and some of the challenges in knowing that we're doing the right thing, and how do we measure the impact of prevention. Tori McGowan is an emergency medicine physician in Oregon, recently wrote an editorial on this concept, and she writes, "When it's all over, the marker of our triumph will be an absence. It'll be the unused cemeteries, delayed funerals, unmourned loss. It will be hard to measure the spoils because we'll only be able to count them in the ghosts of our fears not realized." So with that, I'm going to pause, and I'll be happy to take your questions.
Okay, great. Thank you. I'm seeing some questions about the interim guidance for critical infrastructure. So can you say a little bit about critical infrastructure and then about the guidance?
Yes. Getting data out and sharing what we're learning is always important, but it's not just an academic exercise. This being a new disease and a new virus, what we learn also then translates into what we do differently. It's one of the reasons why you'll see recommendations that are updated and may change. Last week we spent some time talking about the expansion of the use of masks for source control to more general use in the community using cloth face coverings. In the instance of critical infrastructure, those guidelines were updated on April 9th, and you can find those on the CDC website. Critical infrastructures include law enforcement, 911 call center employees, fusion center employees, hazardous material responders from both government and the private sector, janitorial staff and other custodial staff, workers in food and agriculture, and particularly in when we talk about food, we're talking about grocery stores or takeout services, critical manufacturing, in information technology, transportation, energy, and also government facilities. In other words, the things that keep us fed, watered, and keep the lights on. So the additional guidelines focus on a number of activities that include being able to identify people who may be potentially infectious and trying to exclude them from the work site. And much of this is driven, like the recommendation for cloth face coverings when in public areas in the community, on the fact that it's now recognized that the period of infectiousness can begin as much as 48 hours before the onset of symptoms, and some proportion of people who become infected will never develop symptoms. It's not clear exactly what role that they may play in the transmission of COVID-19, but it's very doubtful that it's zero. So some of the recommendations include that employers should measure employees' temperatures and assess symptoms prior to starting work. And ideally, these temperature checks should happen as the individual enters the facility. As we've discussed in previous calls, a temperature check doesn't absolutely exclude someone who has COVID-19, but it is a way to identify people who perhaps definitely should not be at work that day. Example, we do this now at the CDC. When I came into the facility today, my temperature was taken with a non-touch temperature gun by a friendly person wearing a face mask as well as a face shield. And then I was read a number of questions about any recent symptoms, as well as exposure to people with documented COVID-19. After clearing that, I was able to then get a sticker that I have affixed to myself now, showing that I've been cleared to enter the facility. I experienced something very similar at a federal building in Washington, D.C. About a week ago. They went with a wristband approach so that everyone could spot who had been appropriately screened. Still, this does not replace some of the basics, such as employees should be separated by at least 6 feet and practice social distancing during work duties. And ideally, a face mask should be worn at all times, and particularly in public work areas. And that areas such as offices, bathrooms, common areas, shared electronic equipment, those high-touch surfaces should be routinely cleaned and disinfected. And there may be additional detailed questions, but I'll pause after that summary.
There is some questions about temperature. So should you take all employees' temperatures or just those you believe are potentially exposed?
Yes, we would recommend that everyone have their temperature taken each day. Just a few little tips on that. If it's chilly outside, it may be hard to get a good temperature reading with a non-touch surface. So if you can ask the employee maybe to pull their shirt collar back just a little bit to be able to get some skin that was not exposed to the ambient temperature outside. If it was a chilly day, you can get a more accurate reading. I think I scared people when I walked in with a temperature of 94 on a cool and breezy day a week ago, but by just showing a little of my collarbone, we got a temperature of 98.2, which I'm sure was much more accurate.
And so there's questions about taking the temperature with the no-touch thermometer, but ensuring social distancing. I think you talked a little bit about that by the healthcare worker wearing a face shield, but can you say a little bit more about that?
Yeah, so people who are doing the no-touch temperature screening ideally should be wearing a mask as well as a face shield, a gown, and gloves to be able to protect themselves. They do not have to change these between each employee. The other thing that I'll mention that can be handy is to be able to put some sort of marker to be able to remind everybody to remain 6 feet apart as they stand in line, or have somebody who can remind people, which I confess I had to be reminded this morning. I stood a little too close to the person in front of me in my great eagerness to get to work.
And then another question on this. So if you have confirmed COVID-19 employees in your facility, should you shut down?
Yeah, so Ideally, the facility should be cleaned and disinfected. So you want to close off the areas where that were used by the person who is sick. Ideally, you want to be able to air out the area and wait 24 hours before cleaning and disinfecting. If 24 hours is not feasible, again, wait as long as possible. And you want to clean and disinfect all the areas used by the person who is sick, such as offices, bathrooms, common areas, shared electronic equipment like tablets, touch screens, keyboards, and remote controls. We experienced this in the Emergency Operations Center at CDC just a couple of weeks ago after one of our people here was confirmed with COVID-19. If it's been more than 7 days since the person who is now confirmed with COVID-19 visited or used the facility, additional cleaning and disinfection is not necessary. But I want to stress that all of us in all work settings need to continue cleaning and disinfection with particular attention to those high-touch surfaces.
So some questions about survivability, and can the virus survive on clothes and shoes, and for how long?
Yeah, so the data on survival of the virus on particularly clothing suggests that it's only for a very short amount of time, and that virus on, even if it is present on clothing, it's ultimately killed with routine laundry. The bigger concern with contamination of environmental surfaces relate to hard surfaces, particularly stainless steel and certain type of plastics. The contamination will generally occur through respiratory droplets from someone who is infected. As I sit here talking, my mask should be catching any respiratory droplets, but to make sure you understand me, I actually have my mask lowered. So if I'm infected, I may be contaminating the surface in front of me. So I will wipe that down with a disinfectant wipe after we're finished. Survival on those kind of surfaces can be longer, potentially on the order of hours. You know, how does it then get from high-touch surfaces or from horizontal surfaces into the respiratory tract? The vector is the hands, so hence the concentration on hand hygiene, the importance of washing hands with soap and water for at least 20 seconds, about as long as it takes to sing Happy Birthday twice or go through the alphabet. I'm wide open to other songs because I'm sick of both of those by now. Or use an alcohol-based hand cleaner with at least 60% alcohol. Those high-touch surfaces, you know, frequently the question is how often to wipe them down, and it really is going to depend on how heavily they're used, but ideally as often as is feasible.
So there still seems to be some confusion between cloth face coverings, face masks, and who needs to wear what, customers, employees, etc.
Yeah. So let's sort of take it from the top in terms of the differences between respirators, masks, and cloth face coverings. And the purposes of each are related. Is it to protect the person wearing it, or is it to basically be what we call source control, that is, to limit spread from someone who is potentially infectious? In the case of respirators, and these are things like the N95 respirators, the purpose is really to filter the air that's inhaled and to protect the wearer. These are supplies that have been very precious in recent weeks and really prioritized for healthcare workers that are at highest risk of being exposed to aerosols from people who are infectious. A number of steps have been taken to be able to preserve the N95 respirators, including recent purchase of units that allow decontamination and sterilization of the mask using vaporized hydrogen peroxide. And those are, to find out if those are available in your area, you can contact your local emergency response coordinator, and specifically the regional emergency coordinator with FEMA could provide more information on if and when those type of units are available in your area. When we talk about masks, we're more often talking about just a simple face covering, such as a surgical mask. So the design of some of the cloth face coverings are like surgical masks. Back in the day, actually all surgical masks were cloth face covering, and they're designed primarily to keep the surgeon from potentially contaminating the surgical field while talking, and to keep any droplets that come out of the mouth or the nose from falling into the patient on the operating table. We also use those as a way to reduce the spread of respiratory droplets from people with any kind of respiratory infection. So it's not a foreign concept. In fact, really from day one of the response, the recommendations for people who are suspected to have COVID-19, who required evaluation in a healthcare environment, that they wear some type of mask to be able to prevent spread of respiratory droplets whenever they're in a public area on their way to get health care. What has changed more recently is the finding that not just people who are symptomatic with COVID-19 may be able to spread the virus. And so the cloth face covering is a way to do the same thing, but without potentially burdening the supply chain for surgical masks. If you have surgical masks available, it's fine to use them, but we can help preserve those by using cloth face coverings. And there's a lot of varieties. Just looking around the room here, I see one that has ear loops on it, also one that I think is purchased, a nice black one that has very long ear loops. I go with more of the classic tie behind the head, like what you see on MASH. And it's basically like an old-fashioned surgical mask, although I express myself a bit by having a fabric that has images of bears and salmon on it. So the goal there is to be able to protect others. And so, for instance, I think specifically when you go into indoor public venues such as stores, it's important that we all be masked, and I've noticed that more and more employees are masked, and I've also had a number of employees thank me for wearing a mask, because they do understand that while I may not be protecting myself, I'm doing it to protect other customers in the store as well as the employees. In other types of work sites, such as the one I'm in right now, I'm not interacting with the public, but out of respect and care for my fellow employees, I'm mostly wearing a mask to be able to reduce the chance of transmission if by any chance I'm asymptomatically infected or have not yet developed symptoms of a recently acquired infection.
Okay, with some questions about the virus. So you had mentioned some of the factors of why it may be higher for African Americans. Do you feel like those are some of the same social determinants of health that might impact Latinos or other racial ethnic groups? Yeah,
and you raise this also a question totally apart but related to race and ethnicity and its socioeconomic conditions. We know that respiratory viruses can be spread more readily in crowded situations and in housing where the number of people per square foot is such that there's more people in contact with others. Also, it can be harder to telework oftentimes if you're in the service industry. So there may be more exposure for people who are in some of the lower income occupations. And again, that's why it's important to wear a mask, not only if you work in those kind of settings, but also if you're a customer. It's a way to protect your fellow human being. And you know, also critical infrastructure. We don't often talk about the people that work on the produce aisle at the grocery store as being critical infrastructure, but they are important people to keep us fed through this time where many of us are quarantined at home in either out of work or working remotely.
And then questions about the spread. So you noted the 6 feet recommendation from CDC. The question is sort of the WHO has 1 meter,
yeah.
And then also do respiratory droplets actually go further than 6 feet?
Right, yeah. So there's nothing magic about 6 feet. In fact, I've always thought it was a little funny. 6 feet is Americanized of another recommendation that's 2 meters, doubling of the WHO recommendation. In general, the closer you are, the higher the risk. And it's important to recognize also that 6 feet is kind of an average when you think about the respiratory droplets that are produced during talking or singing, coughing or sneezing, but certainly a sneeze is able to project droplets for a further distance. A champion watermelon seed spitter may be able to go 8 meters or more. So it's not an all or none phenomenon, but 6 feet is a good rule of thumb to be able to limit the amount of exposure to respiratory droplets from someone who is potentially infectious. That alone, though, I think is not enough, so that's why the cloth face coverings are important. That's why staying home if you're sick is critically important, and also practicing good hand hygiene is important.
We received some questions, like we usually do, about what we know now about immunity and when this might be over.
So hot topic for the week, and something we'll be learning more about very soon. Some of the work CDC has been involved in has been setting up systems to be able to monitor the prevalence of antibody in the population and locations around the country. Particularly now that we recognize that some people are infected without symptoms, it's important to know what proportion of the population has already been exposed. A second part of that question is whether or not the antibodies that are detected through the commercial tests that are becoming available, as well as the enzyme-linked immunosorbent assay test that we have here at CDC, is a reflection of actual protection. So that's something that I hope maybe by, if not next week, 2 weeks from now, we can start talking about some more definite findings. The hope is that we would be able to determine who has been exposed and potentially protected, and that may open up opportunities for who can return to work, particularly in the types of work that are shut down right now, and to be able to provide proof of immunity. Not unlike what's done for kids being able to go to school when they have proof of immunity through vaccination, but that's an area that's evolving very, very quickly. So we'll know more about that very soon. The one thing that I'll say that's important to know about antibody testing is that antibodies, it appears, do not develop until into the 2nd week of illness for people who become symptomatic. So it's not going to be useful as a way to diagnose acute infections. For instance, if you develop sore throat, fever, and cough today, you most likely have no detectable antibodies. So still a swab for PCR is the optimal way to be able to make the diagnosis.
Questions similar to those we've received before, but about sort of the trifecta of COVID, the flu, and allergies, and wondering if you're going to screen out employees who have allergies.
Yes, that's a great question because we know that it is allergy season in an increasing portion of the country right now. We're by a window, and I can see some of the yellow clouds stirred up by the wind of the pollen here in Atlanta. Allergies will not cause fever, so the value of fever screening may actually be greater as we get into this time of year. And of course, symptoms such as runny nose, a scratchy throat, a rough voice can certainly be caused by the postnasal drip of allergies as well. If you've never had allergies before and you have those symptoms, I think that would be a reason to be concerned. For people who have allergies, generally, if you know what your allergies have been like in the past, you can use that as a rule of thumb. But I think it's very important to recognize that things like fever, headache, muscle ache, particularly shortness of breath, are signs of something much more serious. I do recognize that allergies sometimes can precipitate asthma attacks, so a cough and shortness of breath may be present with that as well, but those may be the kind of things that really reflect that you should stay at home and be able to manage the illness if it's allergy or asthma, or if it's COVID, to be able to reduce the risk of transmitting to others. And of course, to state the obvious, if you're short of breath or experiencing chest pain, those are the kind of things that really do require urgent medical evaluation. So calling 911 is probably the best approach unless you're able to get yourself to emergency care under your own power.
So we have a question here that CDC uses two terms, cleaning and disinfecting. What's the difference between these two?
Yeah, so when we talk about cleaning, we're talking about removing dirt and grime. Oftentimes we're talking about the things that are more visible, whereas disinfecting is using the types of chemicals that are approved by the EPA for killing various types of viruses and bacteria. So examples of disinfectants include bleach, they include hydrogen peroxide, they include alcohol. Soap and water are necessarily always thought of as disinfectants, but for enveloped viruses, they're generally killed by the action of soap and water. But that's basically, you can clean and disinfect at the same time if you're using a material or a product that contains the chemicals that are marked to be able to kill viruses. A number of products actually show an indication for coronavirus based on experience with other coronaviruses, but all evidence is that the new coronavirus that causes COVID-19, that is still known as SARS-CoV-2, is inactivated just as the other coronaviruses are.
There's a question here about if we have an estimate of either those who are low symptomatic or asymptomatic, and how that might impact the screening folks that are coming into the workplace.
Yeah, so this gets back to the question of why it's so important to be able to take steps to prevent transmission from people who are not yet symptomatic. The cloth face covering is an important way to limit the spread of respiratory droplets. Being able to support hand hygiene and encouraging hand hygiene is important, and also cleaning and disinfecting of those high-touch surfaces is important as well. A question that we're still getting our hands around is what proportion of all infections are asymptomatic. There's some data from Iceland that suggested it was 50%. There's been other data that suggests it's much lower. So at this point in time, I think all bets are off. There is some proportion of people who are asymptomatic when they become infected. As we get more of the data from serological surveys, I think we'll have a much better handle on that.
And then can you say a little bit more about sort of the broader opening up again or returning to work, and I think maybe an analogy of like, is it a light switch or more of a roll back or like a dimmer?
Yeah, maybe it's more like opening the shades where you turn it very slowly and let in just the right amount of light. It's definitely not a light switch because the scale back could, if it's too sudden, we'll see a resurgence in cases and a second wave that could be even worse than the first one. So it's something that will need to be done very carefully. What we want to make sure is in place is that we have a healthcare system that is not totally stressed out, but able to handle any increase in the number of cases. We want to continue to build the capacity to make the laboratory diagnoses so that we can determine who has COVID-19, and also be able to do the investigations around cases to be able to ensure that people who have been exposed are aware of their exposure status and can take appropriate steps that would limit spread to others. And of course, to state the obvious, we would want to see that we're on the downward trend. While some of the recent data nationally and the data from some of the areas that have been heavily impacted early on, particularly in New York City and in New Orleans, we're seeing some decline in the rate of increase, but the number of cases still isn't cumulatively or going down again. We haven't seen a day where we saw a significant reduction in the number of cases. When we begin seeing that happening, that's when I think we can start talking about in locales how we might loosen up. And I want to stress that while everybody wants national guidelines on that, I think national guidelines is the best we can do, because there are areas of the country that have been less impacted than others, and we want to make sure that we don't see situations that approach a crisis point, such as in New York City, where there was such a rapid increase in the number of cases over such a short period of time. And I just really want to salute healthcare providers all across the country, but particularly in New York City, as well as the public health officials, just really rapidly ramping up to be able to deal with the influx of the patients coming into the healthcare system, as well as the rapid increase in the number of cases. And it's encouraging to see that the number of cases is not increasing as rapidly, and there's even some evidence that the number of persons who are hospitalized with COVID-19 have begun to decline. We would want to see that over a period of more than just a couple of days, but those are encouraging signs that what we're doing is working, but we've got to be very careful about not changing a winning game plan too early.
A couple of questions that have come up before about when if your workplace doesn't allow for 6 feet of separation between employees, maybe they're on a manufacturing line or somewhere that doesn't allow that.
Yeah, well, it's really important for employees to take every step that's possible to be able to allow that. And it's, the recommendations have to be adopted to the individual work environment. An example that I know of where that was simply not possible was in air traffic control, and I may have mentioned this last week. Air traffic control towers can be fairly crowded environments. It's also an area where being able to speak clearly is critically important. And so those are situations where being able to monitor for temperature and symptoms, as well as ideally being able to exclude people with known exposures, is important.
And then less workplace related, but last week you talked about a tiger. Do you know any more about COVID in animals?
Yes. Last week we learned about Nadia, who was a tiger in the Bronx Zoo who was diagnosed with COVID-19. Last count I saw, there were 4 tigers and 3 lions in the Bronx Zoo that had been diagnosed with COVID-19. And speaking of occupational hazard, I am told the veterinarians that collected those specimens did sedate the animals before collecting an MP swab. There was a zoo employee that was involved in care of these animals who had COVID-19 and had mild symptoms. So the evidence is actually that it's very possible that the virus had passed from this human to these feline species. There have been studies in China inoculating a variety of animal species, and they did have some success in inoculating cats, no success in inoculating dogs, chickens, pigs, or ducks. So at this point in time, we have no evidence of ongoing or common transmission from animals to humans, but the CDC guidelines do recommend, if you're symptomatic with COVID-19, ideally having somebody else take care of pets to be able to reduce the risk of that transmission. And that may be particularly important if we're talking about cats, since at least in the laboratory and in one real-world instance, it appears to have been feasible to transmit the virus to the animal. But I'll stress again in conclusion that while the initial spread of the mutated virus most likely was from an animal to humans, this virus is well adapted to be transmitted person to person, and we're not seeing a lot of evidence at this time of transmission from other animals to humans. That said, of course, I'll say again, we're talking about a virus and a disease that we didn't even know existed only 4 months ago. So it's humbling to learn more as we go forward. But those are the guidelines based on the science that we have right now.
Thank you. So that brings us to the end of our time today. Do you have any closing comments?
I just want to thank you for your interest and thank you for being here. This is just a remarkable time, and it takes all of us working together to get through this. But it's important to recognize that we will get through this. There will be too many losses, there'll be too many funerals, and so I do want to recognize that. But the fact is, our America will get through this, as will the rest of the world. But we still have a long way to go in this pandemic. So I appreciate the chance to talk with you today, and I hope that I'll have the opportunity to share what more we're learning about how to control COVID-19 and prevent infection and death in the near future.
Thank you all for joining us this afternoon. This concludes our session.
Thank you, everyone.